In the last video, I talked about the hyperkalemia protocol and the fact that it can be frustrating when the patient doesn't appreciate your effort. In this video, I'll talk through the actual protocol itself and the things that you need to do for the patient with high potassium. This is a protocol for my hospital, so Northern Ireland Western Trust. It will be different in different hospital, obviously, but I think generally it should be quite similar, isn't it? So when chasing bloods, if you see the level is above 5.5, then that should trigger some alarm in you. Usually 5.5 to 5.9, it's quite mild. You don't need to do much. Just check whether the patient is okay or not. But when it comes to over 6.0 and above 6.5, then that's the time that you need to initiate it no matter what. So the ECG, if you do it, you can look at here. ECG of a hyperkalemia will have tau 10 T wave, and that's probably the most obvious sign that you could see on a ECG, as well as with a wide QRS complex. So over here, the ECG that I saw in that patient with a potassium of 6.5 had none of these, but because it's 6.5, so you just start it immediately, no matter what. So first off, you give, hopefully you can see my cursor. Let me bring up. Yeah, no, maybe green. Yeah, green. So first of all, you give 30 mils of IV calcium gluconase over 10 minutes, and this is to help protect the heart. I think the mechanism is that it blocks the potassium receptor on the heart so that the high potassium is not going to affect the rhythm of it. Given with 10 minutes, so which means that you're giving it very slow, that every 10 mil is about 3 minutes, just giving it slowly. Then after that, you check the blood glucose because we're going to give the insulin. So we need to check her baseline glucose to prevent any hypoglycemia events. Then you give 10 units of rapid 15 mils of glucose, 5 minutes. Oh, I was wrong. So 5 minutes. I said 15 minutes in the last video. Actually, it's 5. And then nebulized salbutamol. So insulin and salbutamol helps move the potassium into cell. The glucose is just to prevent the hypoglycemia events. After that, you ask the nurse to check the blood glucose. If it is less than 7, you give some glucose fluids. If it's above, then it's fine. It doesn't matter. After that, you give Lokelma, 10 gram. What? 10 gram? Yeah, 10 gram. 10 gram TDS, and then put it on stat. You write it as stat, and then these ones you write it in regular sections. In terms of the mechanism of it, Lokelma is, I don't know much about it, but it helps block the potassium receptor in your GI tract, and it's quite a fast-acting medication. As a result, it will help prevent more potassium being reabsorbed into the body system. And then after that, you turn over the page. Turn it over, you'll see this. And let me show you. So let's say it was, what's the date today? 30, 11, 24. You write it was 4:40, 45 when I roughly initiated. So 15 minutes, that'll be, oh, sorry, it should be like this. And then, so that's 30 minutes from there. And then like that, you write down the time for the nurses. And you can see that every time period, there's a blood glucose check just to ensure that the patient doesn't go hypo. The serum potassium was checked every hour and 4 hourly. You need to hand this over to the on-call team for them to chase the bloods. Then over here, if the potassium level is still high, then you might need to repeat it again. If it is 6.0 to 6.4, then just send it again just to make sure that it's actual truth. And contact your SHO to see whether you want to do the blood in an hour or reinitiated the protocol again. Less than 6 is perfect, like nothing needs to be done. If we write down the actual overall management of it, is this. So if you see a potassium of more than 5.5, you quickly do a A to E assessment. You just check whether the patient is feeling all right, any palpitations, any chest pain, feel the pulse, and then follow the guidelines. You check the ECG to ensure that there's no tau tensor T wave, shown like this. And then still recommend to call the SHO to let him know that, oh, the level is pretty high. Start the hyperkalemia protocol. If the patient is aggressive, dance with them, battle with them, give the 10-minute calcium gluconase and 5 minutes of insulin glucose. Just give it. Then after that, there was once I forgot to prescribe on the Cardex, which is quite a bad error. So make sure you remember to prescribe them in the Cardex. Then important things that I forgot I forgot to do. I was reminded by my consultant is that you come to BNF and then you go up to the top, you press appendix, the appendix 1, and then hyperkalemia. I always forget to do this, but you should stop some of the medications that increase the potassium in the cell, especially the ACE inhibitors. I think it was written over here, down here below. Yeah, here. So I always forget these. You stop some of the medications to prevent more potassium being shot inside their body. Then you hold them. Tell the nurse about the blood glucose, use and needs to check regularly, and then write in the notes. I forgot the notes. Generally, that's the management for hyperkalemia. It has a lot of things to remember, as well as things to be done, or else you'll forget. But good things as a doctor is that you don't need to remember them. You can just check the protocol compared to a medical student where you just have to remember them and then explain it to the examiner. If there's any questions on hyperkalemia or things that I didn't explain well enough or I made error, feel free to comment below. But thanks for watching and I'll see you in the next video. Bye!